And they were like, it's beautiful, visual, everything is visible, but like the efficiency was quite the same. And there were some studies that were in favor for volumetric ultrasound, but when one looked into the case, it was one was published by, to be honest, in the Egyptian annual radiology. And when you looked into the results, everything was insignificant when it came to the statistics. So they said that the conclusions are in favor for efficiency, but it was insignificant.
Okay, so at your side, the volumetric approach is not used neither for characterizing the lesion nor for
exactly.
biopsy. Okay, thank you. A great talk.
Thank you. I also think that this great educational value of your work. I would like to see some materials and methods which would use your own experience in this presentation. So it would really improve the value of this work, I think.
You mean apart from the films?
Apart from the films, yeah.
Mm-hmm. Okay. Thank you very much.
Thank you.
Thank you very much for the discussion and for your presentation. Następna prezentacja to prezentacja pod tytułem Assessment of Anxiety and Depression in Patients with Cardiac Implantable Devices Prior to MRI Scans.
Honorable Commission, ladies and gentlemen, good afternoon. I'm here today representing my team. Our study is titled The Assessment of Anxiety and Depression in Patients with Cardiac Implantable Electronic Devices Prior to Magnetic Resonance Imaging Scans. This research aims to shed light on the psychological impact of these procedures in patients with CIDs, in short. Magnetic resonance imaging in patients with CIDs is assumed to have an elevated risk of adverse events. Therefore, it is required to have a dedicated magnetic resonance pulse oximeter and the supervision of cardiologists throughout the whole examination. The aim of our study was to assess the levels of anxiety and depression in patients with cardiac implantable devices prior to magnetic resonance scans, and make a correlation with selected socio-demographic data. Let's move to the materials and methods section. My team personally participated in all MRI procedures. We conducted patients' interviews, then assessed the responses on a scale, which will be mentioned on the next slides. All patients were examined using the MRI scanner GE 1.5 Tesla gemsuit at the Upper Silesian Medical Center, named after Professor Leszek Giec of Silesian Medical University in Katowice. All patients were monitored throughout the examination, as I mentioned, and there was a constant supervision of a cardiologist that programmed the devices to minimize the possibility of significant interaction with the strong magnetic field generated by the MRI scanner. Our included population consisted of 25 women and 67 men, 92 patients in total. The median age of patient was 65.6, and the mean age was 65.6, and the median age was 68.5. The facility mentioned above conducted about 300 examinations since 2016, and it is one of the most frequently conducting facilities in Poland, because MRI procedures in patients with CIDs are the infrequent examination in Poland. We assessed the patients with hospital anxiety and depression scale of modified version. It consists 16 statements. Each rated on a 4-point scale. It is used to assess anxiety and depression measurements. We made a conversation with each patient, then assessed the responses on a scale and summarized the score. For each variable, score between 0 and 7 are considered normal. Scores between 8 and 10 fall within the borderline range, and scores of 11 and above are considered at a pathological level. Our results was followed. If it comes to depression, the mean value was 4.41, and the anxiety mean value was 5.85. There was statistically significant correlation of depression with age, but there was no statistically significant correlation of anxiety with age. If it comes to anxiety, women have showed an increased level of anxiety compared to men at a statistically significant degree. When it comes to depression, there was no statistical significant difference. The frequency of measured scores are displayed on a presentation if it comes to anxiety, and in terms of depression, it shows like this. In conclusion, our findings highlight the importance of pre-MRI procedure psychological assessment, particularly in a vulnerable population that our study showed might be women and person living in urban areas compared to rural. We continue the following study to assess the measured variables after 4 weeks after examination, and we hope that our findings will be available on the next Silesian Medical Congress in Katowice. Thank you for your attention.
Thank you very much for your presentation, and we are waiting for the questions. Of course, all participants can ask the questions.
Congratulations. It is very interesting study, as I was sure that the depression and anxiety before the MRI in patients with implantable devices, it is the problem of a doctor, not a patient. So it is really very interesting, especially for me, as I do perform such exams without the devices, as I think that it is impossible to perform it in outpatient clinic. So you have got really unique experience. So you divided the scale on depression and anxiety basing on your scale.
We performed the questionnaire. We used hospital anxiety and depression scale, which is validated to use in Polish society, so there was no need for the control group. And the scores that I mentioned of normal, considered normal, on borderline range, and on a pathological degree, was known from the hospital anxiety and depression scale.
Thank you very much. Do you have any proposal how to explain the patients to the patient that it wouldn't be any problem with the exam?
A meta-analysis data has showed that the probability of a significant risk of interaction with a strong magnetic field is minimal. So it is assumed to have an elevated risk, but since 2016, the facility hasn't had any significant adverse events associated with that procedure.
Okay, so there is the issue that the patient must be sure when was the implantation and really what kind of device was implanted.
Partially, there are magnetic resonance safe devices, but meta-analysis show that even if a device isn't officially allowed to use in MRI environment, the risks are considered minimal.
Yeah, but it is still the risk, so
yes,
don't perform it. Yeah. I would suggest to divide your patients into the groups, considering the different kinds of magnetic resonance, because I think that it is a huge difference between the heart MRI and, for example, the knee MRI, because the anxiety would be totally different.
Thank you for your comments. Yes, I agree. It's a value comment for the future perspectives.
Congratulations. Thank you.
Thank you.
So just to be sure, no questionnaire was taken from patient without any implantable devices.
No, we haven't had any control group.
Okay, yes. In my opinion, that would be really valuable to have even a small control group, because in my opinion, MRI exam can give anxiety and depression to even patients without implantable devices. Yeah, especially cardiac, as it's quite a long and an exhausting study for a patient and those who perform as well. Yeah. Anyway, it's valuable work, and a lot of your own input was really visible in the talk. Thank you.
My only comment was the same that Oscar just said, just about the control group. That's it, basically. I think it's yes, that would be very valuable to compare these two groups. But still, thank you.
Thank you for your comments and suggestions. We will take it as a consideration for the future perspectives.
Thank you very much. Kolejna prezentacja nosi tytuł Work-Related Musculoskeletal Disorders in Polish Sonographers, a Questionnaire Study.
Good afternoon, ladies and gentlemen. I am honored to be here to talk about musculoskeletal disorders in Polish sonographers. My name is Marcin Ciekarski. I am 6th year. Good afternoon, ladies and gentlemen. It's an honor to be here to talk about work-related musculoskeletal disorders in Polish sonographers. My name is Marcin Ciekarski. I am a 6th year medical student. WSMDs, or work-related musculoskeletal disorders, are conditions that are caused or aggravated by workplace activities. These painful conditions are caused by damage to the nerves, tendons, ligaments, or tendons. And unlike acute injuries, they develop gradually over a period of time from repeated exposure to risk factors and can be painful during work or at rest. The aim of our study was to assess the prevalence and intensity of pain among Polish doctors performing ultrasound examinations. The study was conducted between July and December 2023. It included 8 medical institutions. The data was gathered anonymously using a structured questionnaire developed by researchers based on surveys used in other studies on this topic. The questionnaire included 19 questions and a comment section addressing personal factors, work-related factors, ergonomics, workload, and musculoskeletal pain. The data was gathered by researchers on printed questionnaires in person. The statistical analysis involved both descriptive statistics and correlation analysis. We gathered data from 19 participants, of whom 46 were women and 44 were men, resulting in almost equal ratio between both genders. The participants ranged from 26 to 74 years old, averaging 43.1 years. The most numerous group of physicians was aged between 30 and 39 years old. Among surveyed physicians, 1 was an intern, 22 were residents, and 67 physicians were specialists. When watching the different specialists and reporting their pain, the most specialists were specializing in radiology and internal medicine in our study. The most common pain occurred in vascular surgeons and obstetric gynecology specialists. And internal medicine specialists and radiology specialists reported the most intense pain during or after the procedure. The most specialists and physicians reported working over 20 hours a week during performing ultrasound examinations, with the average number of examinations being of 50 to 100 examinations weekly. When looking at the types of examinations performed, the most common types were abdomen, neck and thyroid, and vascular Doppler ultrasounds. The physicians most frequently reported pain during performing obstetric, gynecological, and breast ultrasound. And the highest pain intensity was reported during transfontanel, musculoskeletal, and vascular Doppler ultrasound. We asked physicians to rate their pain on a scale of 1 to 10. From the whole group, 59 physicians, which accounts for 2/3 of the whole group, reported the pain. The median of the pain was 6.17. The mean of the pain was 6.17, with the median of 6, minimum of 2, and maximum of 10 among these 59 physicians. We asked the physicians to rate their association of pain with ultrasound procedures. Most of physicians, on a scale of 1 to 10, most of physicians rated their association of pain with ultrasound procedure on 4, which meant very strong association. When it comes to pain location, most physicians reported pain in the spine region, especially cervical and lumbosacral spine, and the pain was least frequently reported in elbow joint and thoracic spine. Correlation analysis revealed that age and gender do not correlate with occurrence of WMSDs. Pursuing a specialty in vascular surgery showed positive correlation, as especially in the lumbosacral region. Specializing in orthopedics displayed a weak negative correlation with discomfort. Longer tenure in ultrasound practice showed a weak positive correlation, as did higher number of weekly examinations. Working predominantly in public sector was negatively correlated with the occurrence of discomfort. Performing obstetric ultrasound examination weekly positively correlated with pain, as did musculoskeletal examinations, and they correlated weekly negatively. Coming to conclusions, WSMDs pose a significant pose a significant risk to Polish sonographers, especially those specializing in surgery, vascular surgery, and obstetrics and gynecology. Interesting finding in our study is that only 10% of the physicians reported training in ergonomics ultrasound work. As a part of What Next, this study was conducted as a collaboration between our radiology department and Silesia University of Technology. At first stage, we wanted to assess the incidence and prevalence of pain in Polish sonographers. At the second stage, we want to observe physicians during examinations, reporting their movements and positions, which may be associated with the strain from the examinations. And on the third stage, we want to develop a prototype device that could assist the physicians reducing their strain in the uncomfortable positions. Thank you for your attention. I am open to further questions and discussion.
Thank you for the presentation. And it's time to start our discussion. From public or from the committee?
Okay, so I would like, so really good talk, thank you. And important subject as I feel the pain right now, or even after thinking about going back to ultrasound site. Anyway, I would like to make a comment in terms of Doppler studies. From my experience, that's very heterogeneous group. Yeah, performing an carotid ultrasound or a lower limb, upper limb, it's heterogeneous and it may give totally different symptoms. In my opinion, making just one group out of the studies, it's a limitation, yeah, of the study. In terms of our ergonomy during work, the outcome of your work is intuitive. Yeah, I feel like in the private sector, I feel like less the pain that working here in this hospital. It may correlate to patient symptoms, how sick is the patient during the study. Yeah, so that's how we feel. The correlation between actual studies and the pain was significant. I might have. Could you go back? Because there was a correlation between specialties, but in terms of actual studies, have we reached a significant correlation?
So when it comes to correlation between the studies, yes, the obstetric ultrasound.
Obstetric, yeah. So, but those are clearly related to a specialty, yeah.
Yeah.
Yeah. So I feel like you probably, if you have a larger group, you would clearly get a correlation between certain studies. Yeah, yeah, but really, really important subject. Although, yeah, so like we all feel the pain. Yeah, so yeah.
Congratulations, very nice work. You have got really a huge group, 90 participants. You have got very nice statistics. I would like just to ask if you divided the joint pain between the site of the site with the transducer and the site without the transducer, because it could be interesting.
Yes, we did it in our questionnaire, but it wasn't significantly statistically significant. Which site was it?
Also interesting. Also interesting. Mm-hmm. And what else? Sorry. Thank you very much.
Thank you.
Thank you very much. Kolejna prezentacja nosi tytuł Investigation of the Transmittance of the Light Beam Used in the Pulse Oximeter through Layers of Various Hybrid Varnishes During Magnetic Resonance Measurements.
Wysoka Komisjo, Szanowni Państwo, nazywam się Martyna Migdał i reprezentuję koło naukowe przy Katedrze Elektroradiologii Śląskiego Uniwersytetu Medycznego. Nasza praca dotyczy badania przepuszczalności wiązki światła obecnej w pulsoksymetrze podczas badania za pomocą rezonansu magnetycznego. Na początek kilka podstawowych informacji. Rezonans magnetyczny to metoda diagnostyczna, która do tworzenia obrazów wykorzystuje fale elektromagnetyczne. Wiązka w pulsoksymetrze istnieje wiązka światła, która ma odpowiednią długość fali. Przenika ona przez tkanki znajdujące się najczęściej w palcu i jest odbierana przez detektor znajdujący się po drugiej stronie nakładki pulsoksymetru. Badanie tętna i saturacji podczas rezonansu magnetycznego jest szczególnie ważne u osób, które posiadają różnego rodzaju wszczepialne urządzenia, takie jak kardiowerter czy kardiostymulator. Pod wpływem silnego pola elektromagnetycznego tego typu urządzenia, zwłaszcza starszej generacji, mogą się po prostu wyłączyć czy przestać działać. Dlatego bardzo istotne jest monitorowanie podstawowych parametrów życiowych u pacjenta. Podczas zajęć w pracowni rezonansu magnetycznego zauważono, iż u osób z pomalowanymi paznokciami lakierem hybrydowym lub żelowym odczyt z pulsoksymetru jest zaburzony lub w ogóle niemożliwy. Sformułowałyśmy tezę, iż konkretne lakiery nie przepuszczają światła emitowanego przez pulsoksymetr. Dlatego celem naszego badania było sprawdzenie, jakie konkretne kolory lakierów hybrydowych uniemożliwiają lub utrudniają badanie za pomocą pulsoksymetru. Do badań wykorzystałyśmy pulsoksymetr marki Nonin 7500FC. Jest to uniwersalny, przenośny pulsoksymetr do zastosowań w warunkach szpitalnych. Jest on w 100% bezpieczny i przystosowany do pracy w warunkach pracowni rezonansu magnetycznego ze względu na wykorzystanie techniki światłowodowej. Teraz kilka słów o lakierach hybrydowych. Lakiery hybrydowe są to takie lakiery, które łączą w sobie cechy tradycyjnego lakieru do paznokci oraz żelu, przez co są trwalsze i bardziej odporne na uszkodzenia. Do utwardzania tego typu lakierów niezbędna jest lampa LED UV, która wykorzystuje diody elektroluminescencyjne ultrafioletowe. Diody LED lampa emituje światło o odpowiedniej długości fali, które aktywuje substancje chemiczne zawarte w lakierze hybrydowym, powodując jego utwardzenie. Do stworzenia próbek użyłyśmy lampy marki Neonail LED Eco 21 W. Na kawałki folii polietylenowej nałożono cienką warstwę bazy hybrydowej marki Neonail Hard Base. W następnej kolejności rozprowadzono dwie cienkie, niewielkie warstwy wybranego kolorowego lakieru hybrydowego, a całość pokryto topem marki Neonail Top Shine Bright No Wipe. Każda warstwa z osobna została utwardzona w lampie łącznie przez 90 sekund. Wszystkie pomiary zostały dokonane na jednej osobie. Przed przystąpieniem do badania upewniono się, iż wybrana osoba ma wyłącznie czystą i naturalną płytkę paznokciową, bez zbędnych odżywek czy lakierów. Pomiar polegał na nałożeniu próbki lakieru na palec wskazujący, na paznokieć u palca wskazującego wybranej osoby i umieszczeniu go w nakładce pulsoksymetru. Każdorazowo pomiar trwał 30 sekund. Dodatkowo przed każdym pomiarem właściwym został dokonany pomiar kontrolny, który miał na celu sprawdzenie początkową saturację u pacjenta. Teraz wnioski. W testach brało udział 77 różnego rodzaju kolorowych lakierów hybrydowych. Z naszych badań wynika, że 69 próbek nie zakłóca odczytu z pulsoksymetru. 3 z nich dają odczyt zaburzony, a 7 próbek uniemożliwia odczyt z pulsoksymetru. Tutaj na tym slajdzie mamy przedstawione, które próbki powodują zakłócenie odczytu. Kolejne slajdy przedstawiają próbki, które w ogóle uniemożliwiają pomiar. Na koniec dodam jeszcze, że w kolejnych etapach badania jest planowane rozszerzenie liczby próbek oraz wykorzystanie różnego rodzaju metod zdobień malowania paznokci oraz ich stylizacji. Dziękuję bardzo za uwagę i zapraszam do dyskusji.
Dziękuję bardzo za prezentację i zapraszam do zadawania pytań zarówno publiczność, jak i komisję.
Bardzo dziękuję za bardzo kreatywną i bardzo interesującą prezentację. Nigdy bym na to nie wpadła w ogóle. Proszę mi powiedzieć, bo chyba mi umknęło, czy to było badanie tylko za pomocą pulsoksymetru, czy w rezonansie magnetycznym?
To było badanie tylko za pomocą pulsoksymetru, który właśnie był specjalnie przystosowany do pracy w rezonansie magnetycznym. My nie przeprowadzałyśmy badań na pacjentach. Właśnie osobą, na której przeprowadzałyśmy badania, była jedna z autorek. Dlatego po prostu mierzyłyśmy puls i saturację nie podczas badania w rezonansie, tylko
urządzeniem, które służy do badania w rezonansie.
Tak. Właśnie dzięki zastosowaniu techniki światłowodowej jest ono specjalnie przystosowane do pracy w rezonansie magnetycznym, ale pomiary nie były wykonywane podczas aktualnego badania w rezonansie magnetycznym.
Rozumiem. A jaka fizyka za tym stoi? Bo ten żel to jest co? To jest polimer, tak? Czyli on nie ma własności feromagnetycznych, czyli on dodatkowo sam w sobie w rezonansie nie powinien zakłócać, tak? Natomiast zakłóca te fale tylko. To jest na tej zasadzie, bo nie rozumiem tego.
Właśnie istnieje dużo lakierów, które, tak jak pani wspomniała, mogą zakłócać również odczyt, dawać po prostu artefakty w badaniu. Jednak nie skupiałyśmy się na tym, tylko i wyłącznie skupiałyśmy się na kolorach, ponieważ właśnie tutaj też jest duża rola producenta, jakiego rodzaju barwnik wykorzysta i jakie po prostu substancje znajdują się w konkretnym lakierze. Nie mamy niestety takiej wiedzy, żeby po prostu interpretować, który konkretnie składnik w lakierze jest odpowiedzialny za na przykład artefakty, czy właśnie nieprzepuszczalność tej wiązki światła obecnej w pulsoksymetrze. Tylko i wyłącznie skupiłyśmy się na kolorach, dlatego nie sprawdzałyśmy kolejnych możliwych na przykład artefaktów podczas rezonansu.
Rozumiem, dziękuję bardzo.
Dziękuję.
Ja właśnie zastanawiałem się nad takim clinical significance tych informacji, które panie uzyskały, państwo. Bo wiadomo, że jakiś tam barwnik na pewno utrudnia odczyt, to wiadomo nie od dziś, pulsoksymetru. Czy to jest, prawdopodobnie pani profesor też myślała o tym składniku właśnie, czy one tam mają jakieś barwniki metaliczne, tak, które jak w farbach do włosów mogą jakieś artefakty powodować. Natomiast ciekawe byłoby pewnie to, że gdyby, bo tam niewiele tych lakierów chyba spowodowało, tak, te zakłócenia, że zdecydowana większość przypuszczała bez problemu tą wiązkę światła.
Tak. Tam 3 próbki dawały nam zakłócony odbiór, a 5 w ogóle nie przypuszczało tego właśnie światła emitowanego z pulsoksymetru.
No właśnie,
Możemy się cofnąć do prezentacji.
Nie musimy.
Okay.
Tylko właśnie chodzi o to, że skoro tych kilku kolorów jest tak mało, to właśnie warto byłoby zerknąć, czy to jest sam barwnik, który nie przypuszcza światła, czy właśnie jakaś komponenta, nie wiem, jakiś glitter, czy jakieś takie, prawda?
Tak, też miałyśmy to na uwadze, miałyśmy takie lakiery. Z naszych badań wynika, że właśnie różnego rodzaju, można powiedzieć, błyszczące elementy na lakierach nie powodowały nieprzepuszczalności. Głównie w dużej mierze były to lakiery ogólnie o ciemnych barwach, głównie odcienie niebieskiego i zielonego.
Które nie przepuszczały?
Które nie przepuszczały lub właśnie dawały zakłócony odczyt. Tam był właśnie wyszczególniony na pewno brązowy, turkusowy i jasnozielony. One dawały właśnie zaburzony odczyt, były ogólnego rodzaju różne problemy w ogóle z połączeniem się pulsoksymetru. Często też właśnie ta detekcja była przerywana po prostu, a reszta lakierów, która właśnie była wyszczególniona w prezentacji na slajdach, to lakiery, które w ogóle uniemożliwiły nam odczyt, w ogóle żadnego pomiaru nie było.
No, tam jedne były ciemne, a drugi ten jeden był właśnie jasny, więc też ciekawe dlaczego.
Tak, właśnie nad tym też się
One
zastanawiałyśmy.
mają jakieś gęstości swoje na przykład, czy... No tak.
Bo właśnie a propos, tam fioletowy był również też wyszczególniony, dość jasny kolor. Miałyśmy dużo lakierów w podobnych odcieniach, tylko innych marek, więc to też dla nas była właśnie zastanawiające, ale doszłyśmy do wniosku, że to musi być szczególny jakiś barwnik po prostu danej marki.
To tylko tutaj można się troszkę pochylić na tym.
Właśnie planujemy rozszerzyć ilość próbek. Mam nadzieję, że podobne ciekawsze wyniki nam wyjdą w następnych badaniach.
A dużo jeszcze tych producentów tam było, bo zabrakło takiej informacji, że na przykład 10 producentów, czy właśnie jeden producent to był?
Było co najmniej 3 było producentów, tylko niestety z racji tego, że to są wszystko, można powiedzieć, prywatne zbiory, nie mieliśmy wiele po prostu tych lakierów różnych marek. Głównie u nas, powiem, że tak powiem, królowały lakiery marki Neonail. Bardzo dużo mieliśmy próbek właśnie tych lakierów. Co stało? Tak, malujemy sobie paznokcie jeszcze. Ale...
Aha.
Dobrze, dziękuję.
Znaczy, może jako komentarz króciutko. No, wydaje mi się, że kluczowe powinno być widmo absorpcyjne, tak? Jakaś taka spektrofotometria tych lakierów, niekoniecznie w formie już utwardzonej i porównanie tego przede wszystkim z długością fali, na jakiej pracuje pulsoksymetr. To jest jedna uwaga. Druga uwaga jest taka, że zabrakło mi jednak próby kontrolnej z pulsoksymetrem nieprzystosowanym do pracy w polu magnetycznym. Pytanie, czy tu jakaś różnica by wystąpiła. Niemniej jest to problem, z którym się spotykamy, może nie aż tak często, ale no uruchomienie pulsoksymetru czasem przysparza nam problemów w pracowni rezonansu magnetycznego z różnych względów. Bardzo dziękuję, to
Dziękuję bardzo.
cenna praca.
Dziękuję.
Również bardzo dziękuję za prezentację. A ja zapraszam na kolejną prezentację pod tytułem Optimizing Radiation Dose in Multiphase Liver CT, The Impact of Patient Size and Positioning, i to będzie praca wygłoszona online. Panie Michale, czy się słyszymy?
Tak, słyszymy się. Już mam nadzieję, że
Tak, widzimy ekran.
będziemy
Proszę
się
jeszcze
widzieć.
włączyć kamerę.
Tak, mam
dokładnie.
nadzieję, że się widzimy.
Tak, widzimy się. Jeszcze proszę uruchomić prezentację.
Oczywiście już tutaj uruchamiam prezentację i mam nadzieję, że będziemy mogli przejść do...
Tak, wszystko działa. Może pan zaczynać.
Dobrze. Good day, dear jury, ladies and gentlemen. My name is Michał Zierski, and together with Marcin Rojek and Maciej Baron, under the mentorship of Dr. Jakub Kufel, we represent the Department of Radiodiagnostics, Interventional Radiology and Nuclear Medicine at the Medical University of Silesia in Katowice. Today, we'll discuss our research on optimizing radiation dose in multiphase liver CT scans. Here's the plan of my presentation. We'll start with introduction, then we'll tell about the aim, materials and methods, results, and then the conclusions. Liver CT scans are crucial for diagnostic liver tumors, cirrhosis, cysts, and inflammation, as well as the monitoring treatment progress. In Poland, 873 liver CT scans exams were conducted in 2022, with the average of 116.5 scans per 1,000 residents annually. This is compared to the global average of 156.6 per 1,000 residents. Given the frequency of these scans, ensuring the safe implementation of paramount due to the potential effects of ionizing radiation, which can vary while influenced by imaging technology and patient characteristics. The aim of our study is to elucidate the influence of patient body size, positioning, and isocenter alignment on the radiation dose in multi-phase liver CT. Our goal is to recommend strategies for personalized dose optimization. We conducted a retrospective analysis of imaging studies performed between January 1st and December 15th of 2023 at the University Hospital in Poland. Data were obtained from the dose and care dose monitoring system by Gerbert. Parameters assessed included patient positioning relative to the isocenter, the extent of imaging, which means abdomen or abdomen with pelvis, number of imaging phases, total dose length product, DLP, and DLP specifically for liver imaging. The study included examinations with 4 phases: native, arterial, venous, and late liver phase. Exclusion criteria involved missing patients' weight and height data, resulting in 258 patients, 80 only abdomen and 178 abdomen plus pelvis. Additionally, the widest abdominal diameter was measured using the HOROS software. Statistical analysis focused on determining relationships between patient characteristics, between BMI, weight, height, and maximum diameter, and isocenter positioning, and to this radiation dose. Here you can see the image from the dose and care system showing the patient placement outside the isocenter, and here in the isocenter. Here we can see the toposcan from the Helios program, which we use to measure the widest point of the patient. In the results section, I would like to answer these 3 questions. So let's move on to this. Oh, sorry. Our results show significant correlation between patient BMI and total DLP or DLP for the liver phase in case involving both the abdomen and pelvis regions. Graphs display here illustrate these correlations, highlighting the patient physics plays a critical role in radiation dose management. The graph 1 shows the correlation between the patient's BMI and the total DLP for the case involving only the abdomen. Higher BMI values generally correlate with the higher radiation dose, suggesting that patient body mass influences the required dose for adequate imaging. Here, the graph number 2 illustrates the similar correlation for cases involving both the abdomen and pelvis, and reinforce the need for adjust dosage based on the BMI. Here we can see the second question. So the further analysis demonstrate the correlation between the patient's maximum width and total DLP for case involving only the abdomen region, as well as both for the abdomen and pelvis regions. These findings emphasize the importance of considering physical dimensions in dose optimization. On graph number 3, we can see the relationship between the patient's maximum width and the total DLP for the abdomen-only cases. Increased body width necessitates higher radiation dose to penetrate the tissue effectively. Graph number 4 shows the correlation for the liver phase, specifically where the similar trends are observed. Here, graph number 4 and 6 display this correlation for cases involving above the abdomen and pelvis, underlying the consistent impact of body width and radiation dose. We also evaluated the effect of patient positioning relative to the isocenter on radiation dose. Graph number 7 shows the distribution of DLP mean value for abdomen-only cases, characterized by whether the patient was positioned correctly at the isocenter. Interestingly, there was no significant differences observed, indicating that other factors may play a more substantial role in this determination. Graph number 8 provides similar data for cases involving both the abdomen and pelvis, with the results echoing the findings from abdomen-only cases. So, coming to the conclusions. In conclusions, our study underscores the necessity for individualized radiation dose optimization strategies that consider patients' size and anatomy. These findings challenges the traditional emphasis on isocenter positioning in dose calculations. Implementing patient-specific dose settings could significantly reduce unnecessary radiation exposure while maintaining diagnostics quality. Ladies and gentlemen, that's all from me. Here you can see, if you can scan the QR code, you can see our bibliography. And that's all from me. Thank you very much, and I'm welcome for any questions.
Thank you very much for your presentation. It's time to start our discussion. Are there any questions from the public or from our committee?
Can we move back to the conclusions, please?
Yes, of course. Yes, these conclusions?
Yes. Give us a minute, please.
Yes, of course.
Yeah. So in terms of rolling, studies that were accepted in the in your analysis. So only the studies with the exact number of phases were counted in. Yeah.
Yes.
So
yes.
Any additional late phases, like delayed for the kidney excretion, were totally cut out of the study.
Yes.
Yeah?
Yes,
Okay.
we only captured patients who conducted 4 phases, which I said before.
No
only
more, no less. Yeah.
No
so
more, no more or less. Yes.
Okay. In terms of BMI, what was the source of your data in terms of BMI?
Yes, it was at first it was just a problem because in the computer system we didn't have the all information needed, so we had to compare from all the other data sets information about the patient's mass and height. So when we gathered all the informations, we compared with the patient's information from the dose and care system. We added to this in an Excel system, the additional column, which we added this information about the patient's height and weight. So we sum it and then we conducted to the analysis.
Okay, so the primary source of information to correlate was the dose and care system, yeah, exclusively.
Yes, this was the primary source of our information, but we had there just some gaps that we have to fill in from the other sources like AMS system.
Okay.
Czyli ja mogę przejść na polski, bo to jest bardzo trudne zagadnienie. Ja gratuluję pracy i temat jest bardzo ważny. Tylko tak, Państwo mierzyli dose length product, tak?
Tak.
Dose length product to jest CTDI volume razy długość skanu.
Yes.
CTDI volume jest mierzona na fantomie.
Yes.
Długość skanu, owszem, może, że tak powiem, się korelować z rozmiarem pacjenta, natomiast sama CTDI volume nie za bardzo. Ja nie za bardzo rozumiem przełożenia tego właśnie, to chyba powinien być wzięty pod uwagę taki size specific, że tak powiem, jednostka.
It's hard to, I will answer in English, just the instructions said. It's hard to me to answer this question. The primary aims of our work was to compare the DLP values to the other factors. Maybe that's right. That the other factors, other measurements should be included in this study. But if we use the dose and care system, which I think it's quite popular and quite often used, the DLP value is just the main value that shows to every patient with this kind of CT scan. I don't know if I can answer this question more. Please tell me if this answer is if I should continue or.
Well, as I said, the problem is very important and very useful and very clinically useful. So I think that you had the help of the physicist.
Yes.
Yeah. Mm-hmm.
We of course had the help of the physicist from the department. So together we decided to compare the DLP values. Other than
so
others.
I think that one additional slide which would explain this dependence between the DLP and the size of the patient would be nice.
Okay. Thank you very much for this opinion. I will take it, and I think it will improve our work in the future. Thank you very much.
Thank you very much for the discussion and for your presentation.
Thank you very much.
Kolejna prezentacja nosi tytuł MSCT Features in Prediction of Histological Differentiation of Pancreatic Neuroendocrine Neoplasm.
Esteemed jury, my colleagues, welcome everybody. My name is Jan Herzyk, and today I'd like to share with you about our investigation, MSCT features in prediction of histological differentiation of pancreatic neuroendocrine neoplasms. But let me firstly thanks for Ms. Professor Kowalczyk for mentoring us. Neuroendocrine neoplasms, especially pancreatic neuroendocrine neoplasms, shortly saying PNEN, is one of the hottest topics in endocrinology and in oncology. Why? Because its incidence is still growing. Currently, we can estimate the incidence like 0.32 per 100,000 patients per year. We can divide them into two main groups. Functioning and non-functioning, and both of them are approximately 50%. They are detected by the symptoms in a functioning group like insulinoma, glucagonoma, and because of presenting metastatic changes found especially in accessible radiological examinations like abdominal ultrasound. According to the guidelines recommended by the Polish Network of Neuroendocrine Tumors, there are some steps we need to perform to explain the treatment and the prognosis. We need to perform histological classification based on WHO 2019 scale. We need to perform, of course, radiological evaluation, mainly CT scans, because MRI is not popular, and we have some troubles to perform MRI because there are not too many machines. And also we can perform a positron emission tomography using 68 gallium. We need to perform all of those examinations because we need to know what to do when we can follow him up, or we need to treat using analogs of somatostatins like this in this option or surgical treatment. So because of the recommendation and because of searching current literature, there are There are no articles which can provide and which can estimate the possibility of higher grading. So we decided to analyze the histological differentiation and multi-sliced computed tomography imaging features of PNENs. What did we do? We performed a retrospective cohort study based on medical history of 157 patients with histologically confirmed PNEN. They were hospitalized at the Department of Neuroendocrine Neoplasms at the Cyglana Street between January 2016 and January 2022. There are only two inclusion criteria: the age of 18 and having a complete medical history. So we collected all the data, including core needle biopsy results, according to the WHO current criteria, and we collected descriptions of CT performed by radiologists with 30 years old experience, and evaluated some selected parameters. What did we find? We find that the size of the tumor, divided in some groups because of potentially surgical treatment, were significant in prediction of grading, while the location was not. Moreover, there are some features like enhancement in arterial phase, especially in hyperdense because the PNENs are rich vascular, infiltration of other organs, dilated duct of Wirsung and large regional intra-abdominal lymph nodes, presence of distant metastasis and hypervascularization were significant in prediction. But infiltration of common bile duct, infiltration of vessels, calcification and cysts were not. For those parameters which were significant, we perform also additional analysis, like multivariable analysis and logistic regression model. And what occurred? Something interesting, because infiltration of other organs and the size more than 20 millimeters occurred that can increase the risk of higher grading, therefore the risk of worse prognosis threefolded. But presence of distant metastasis occurred the most dangerous feature. It increased the risk of higher grading approximately fourfolded. So to sum up, now I'd like to switch off the light and show you some CT scans where we can find those features. Here we can see CT scan, of course, in arterial phase. Here in the head of pancreas is a hypertensive change. It's our tumor with hypervascularization. Here we can see the dilated duct of Wirsung, approximately 4.6 centimeters. The norm is up to 3 or 3.5 centimeters. Here we can see enlarged regional intra-abdominal lymph nodes. Of course, here's our lymph node, of course, measured in a short diameter, 1.1 centimeter, and the norm is up to 1 centimeter. Of course, in a short diameter. And the most clinical usefulness changes, infiltration of other organs. Here we can see the infiltration of spleen, but there are also infiltration of gastric or liver, which, as I mentioned, increased the risk of higher grading threefolded, and the size, now we cannot find any limits, any borders of those tumors, which can also increase the higher grading. And the most was change, presence of distant metastasis. Here we can see also an arterial phase with hyperdensive changes, uncountable changes in liver, and uncountable changes, but not too much enhanced in those phase in spleen. Also here there is also a change, but hypotensive because it's not arterial phase. So MSCT can be useful in prediction. MSCT features can be useful in the prediction of those changes. And in this pancreatic neuroendocrine neoplasms. Thank you for your attention. And now I'm open to any questions.
Thank you very much for your presentation. It's time for discussion.
Thank you. What does the literature say about this correlation?
The literature says not too much. In the recommendation held by Professor Koskudła, we can read that, for example, presence of cyst is most common in adenocarcinoma, but there are not many articles which can explain and search in neuroendocrine tumors because of its incidence is not as big. So they suggest that also, of course, distant metastasis and presence of infiltration can increase the risk of higher grading, but there are no statistical proofs. Moreover, it's not easy because we need to also perform a nuclear medicine examination like this PET-CT, and we can, for example, examine the somatostatin receptors, and when we can give somatostatin for the patient, they follow up is better and better.
Congratulations, huge group of patients and very important from the clinical point of view. So would you recommend to omit the histopathological examination and base our patient management only on the basis of CT study?
No, it's not allowed. Histological confirmation is the most important thing. For example, when we can move back to the slide with presence of distant metastasis, I'd like to show you that those parameters can also increase the risk of higher grading. But this picture here can also be an adenocarcinoma tumor. The treatment in adenocarcinoma is not allowed to use, for example, analogs of somatostatin. And the follow-up of those patients is worse and worse than patients with PNEN. For example, 5-year survival in adenocarcinoma in like this stage is 3 or 5%, but in this stage, according to the guidelines, is approximately 5-year survive. I say it's approximately 16 or 20%. So the histopathological examination is necessary.
On the pathology side, you analyzed only the final grading, yeah, from G1 to
to G3, and including neuroendocrine carcinoma.
Okay, and no other factors from the pathology side, like Ki67?
Yes, Ki67, but Ki67 was when we have an histopathological result, there are some WHO criteria, and they classified the grading according to the Ki67. But we also measured it. We tried to correlate it, but the correlation was significant. But we did not include it because it was the it was included in the criteria.
Final G, okay. Yeah, because you had many factors on one side, yeah, and only the final, which is reasonable, on the pathology side. Anyway, so the multivariant analysis could be potentially worthy to perform, yeah, in terms of other factors, just like 4 groups, yeah, in the final. Thank you. But anyway, a really, really important talk, especially regarding the low prevalence of neuroendocrine tumors and lack of evidence, despite what we were listening to is somehow intuitive, yeah. But lack of evidence makes this work really, really valuable. Thank you.
Thank you. No, because of this Department of Neuroendocrine Tumors, this paper could be performed. Thank you.
Thank you very much. Czas na przedostatnią prezentację tej sesji. Nosi na tytuł Analysis of Radiation Dose Absorbed by Vascular Surgery Patients.
Good afternoon, ladies and gentlemen. My name is Marcin Starkowski. I am a third-year medical student at the Medical University of Silesia. And on behalf of all the co-authors, I would like to present the presentation on the analysis that we conducted. And the title is Analysis of Radiation Doses Absorbed by Vascular Surgery Patients. Here's the table of contents. Gamma radiation has become a very commonly used tool in the diagnostic processes. It is utilized for diagnostic and therapeutic purposes, such as computed tomography and angiography. Angiography is used to image structural and anatomical details of the vascular system by detecting a contrast which was injected into the vessels and then projecting this on a series of X-rays, which allows us to show flow through the lumen and outline the inner wall. And here in the figures 2 and 3, you can see exemplary angiographies, both of which were conducted at the Upper Silesian Medical Center. Figure number 4 shows angiography, but we can also see already inserted carotid stent. Figure number 5 shows also an angiography with an inserted aortic abdominal stent graft. And figure number 6 shows angiography of aortic branched stent graft. In the procedures that use gamma radiation, the dose which is considered safe is up to 100 milligrays. And when the dose goes above this amount, the circumstances have to be very specific in order to allow that. And in comparison, the natural radiation in Poland, for example, is 2.4 milligrays per year, which is caused, for example, by the sun. And here on the chart, we can see average effective doses of commonly used imaging procedures. The aim of our research was to analyze the doses absorbed by vascular surgery patients and compare these doses to safe levels, which I mentioned. We analyzed doses of 300 patients in total. All of them were admitted to the Department of General Surgery, Vascular Surgery, Angiology and Phlebology at the Upper Silesian Medical Center in Katowice. They were admitted between March 2022 and April 2024, and were treated with particular kinds of angiographic procedures. The first group of patients which underwent angiography included 50 patients. The second group of patients who underwent implantation of the carotid stent included 100 patients. The third group which underwent the implantation of the aortic branch stent graft included 50 patients. And the last group was a group of patients who underwent the implantation of the abdominal aortic stent graft, and that was 100 patients. Moving into the results, the average doses absorbed between each group were definitely noticeable. In the group of patients who underwent the angiography, the average dose absorbed was 231.74 milligrays. In the second group, so the one who underwent the carotid stent implantation, the average dose absorbed was 86.67 milligrays. The third group, so the patients who underwent the implantation of the aortic abdominal stent graft. The average dose absorbed was 1,154.25 milligrams. And in the group of patients who underwent the implantation of the aortic branched stent graft, the average dose was 2,853.36 milligrams. So as we can see, only in the second group, so the group of patients who underwent the implantation of the carotid stent, the safe dose wasn't exceeded. Moving into the details in each group, in the group of patients who underwent angiography, the doses varied from 2 milligrams, as we can see on the chart, up to 2,369 milligrams. And in 16 out of 50 cases that we analyzed, the safe dose was exceeded. In the group of patients who underwent the implantation of the carotid stent, the doses varied from 9 milligrams up to 354 milligrams. And in this case, 24 out of 100 patients noted the dose above the safe 100 milligrams. In the next group, which underwent the implantation of the abdominal aortic stent graft, the doses varied from 105 milligrams up to 7,315 milligrams. So as you can see, all of the doses noted were above the safe 100 milligrams. And in the last group, a group of patients who underwent the implantation of the aortic branched stent graft, the doses varied from 663 milligrams up to 12,140 milligrams. So here we have the same case as in the previous group because all the doses noted were above 100 milligrams. Such extensive exposure to gamma radiation may have some potential harmful consequences for the patient. Some of them include edema, inflammatory responses, necrosis of the digestive tract, lung fibrosis, erythema in the skin, and increased intracranial pressure in the central nervous system. This ionization also produces free radicals, which can indirectly damage the DNA of a human cell, which might lead to a high risk of developing some types of cancer. Some of them include lung cancer, breast cancer, brain cancer, leukemia, and lymphoma. In conclusion, all of the patients who undergo the procedures which I mentioned previously are at risk of absorbing large amounts of radiation. And as a result, may develop a high risk of developing malignancy or X-ray exposure consequences. Although there are many risks which I mentioned, these procedures are medically necessary, so we can say that the benefits of these procedures outweigh the risks. And after extensive exposure to gamma radiation, all patients should be followed up. Here are the references, and that's everything we prepared. Thank you so much.
Thank you for your presentation. And now it's time for the questions.
The question is, are there any recommendations towards, decreasing the amount of radiation doses for patients during these procedures? And if there are, I don't know if there actually are those the recommendations like those. Is there any chance to, as a conclusions to your findings, to your research, do you have any suggestions for the surgeons performing those procedures, what to do to decrease those? Is it even possible? Because as you said, the benefits outweigh the risks. But are those doses that the patients received, which were impressive,
pretty high sometimes, yeah.
Is it normal, or is it
well, it depends
on the person who's performing those procedures?
Well, definitely it depends on the complications during some procedures. Of course, some procedures are medically much more challenging, and also it often depends on the experience of the person performing, because we personally also sometimes saw when there was help needed in order to, for example, insert a stent, which I talked about.
Congratulations, you also have quite a huge group of patients, and the topic is very important. I would suggest to perform the control study and the operator would not be a surgeon, but for example, a radiologist. I think that it could matter. Because the main problem is the length of the scopy. Did you measure it?
No, unfortunately, we weren't able to measure.
Yeah, please do it because there are such values, and you can easily have it, and it is measurable value. So you could compare the procedure with the length of the fluoroscopy. The first problem. What was the source of the radiation in your study?
The source of radiation was the angiography machine, which were used.
So you cannot talk about the gamma radiation. It is X-ray radiation.
Yes, but the lengths of the wave used are pretty much the same. I know that there's a difference, but
it is important, and it is really a basic difference, okay? Because you cannot talk during such a conference and just to change because gamma radiation it has the length of the wave is really equal. However, the source is totally different. Okay?
Thank you.
It was a single center study, yeah. So all the patients underwent the procedure in the same site. So there are many factors that could be analyzed among other centers, yeah, including the hardware, including operators, patients, how bad the condition is, yeah. So those are the limitations of the study that, in my opinion, should be mentioned in your presentation. In terms of question, what was the source of the radiation dose? Was it taken from a book from the angiography from the cath lab, or
the safe dose?
No, I mean the dose collected by the patient. What was the reporting mechanism?
It was taken from the book that is at the.
In the cath lab?
Yes, definitely.
Okay. Yeah. And was the single parameter that was available was the collected dose?
There was also the parameter which was the radiation per square meter, but we, unfortunately, due to the length of the presentation, we weren't able to take it into.
Okay. Yeah. Oh, so thank you.
I think that when the dose is over the limit, it should be reported, and such a patient should be observed because in Poland we have got the so-called ustawa o bezpiecznym stosowaniu promieniowania jonizującego. There is strictly the management of such a patient is strictly described. Maybe it would be interested if in your institution such a patients are then reported to the SANEPID and so on.
We talked to one of the radiologists, and this person said that when the dose is above 1.7 grays, the patients are definitely kept at the hospital for a closer observation. Thank you.
Thank you very much. I czas na ostatnią prezentację zatytułowaną Factors Impacting the Recanalization of an Aneurysm After Flow Diverter Implantation.
Ladies and gentlemen, honorable jury board, I have an immense pleasure to present to you the results of mine and my colleagues' work concerning factors impacting the recanalization of an aneurysm after a flow diverter device implantation. So, as we know, As we know, around 3% of general population has one or multiple aneurysms. And they are often asymptomatic and up until the moment that they burst. And when they do burst, the mortality reaches up to 50%. And for that reason, I like to call them the silent killers. But fortunately, But fortunately, sometimes before they burst, they can be an incidental finding in angio CT or MRI scans. And when we do spot them, we have to treat them. And we do that mainly using endovascular methods. And a common way in those methods is femoral artery cauterization, which is shown on the slide above. There are various approaches for endovascularly treating an aneurysm, and one of them is coiling. We can also have stent-assisted coiling, and the last one is flow diversion, on which I am talking about today. And the right approach is decided by the expertise of a team of interventional radiologists, and it is based on the patient's age, concomitant diseases, and other factors that may impact the procedure. There are various indications for a flow diverter implantation, and it is most commonly used to treat small aneurysms or aneurysm that has a very wide neck, and also distal aneurysms. And distal aneurysms are the ones that are located beyond the major bifurcation of the middle cerebral artery. And on the graph above, very simplified graph, you can see how a flow diverter device works. Firstly, we have an active aneurysm with blood flowing inside. And this type of aneurysm is very prone to bursting, so it is a life-threatening situation. And when the flow diverter device is implanted, blood clots start to form on either side of the device, which then leads to forming an arterial lining over the device, which limits the blood flow. But there are some factors in which the recanalization of an aneurysm can happen. As we know, it can be really difficult to retreat once treated aneurysm. So we decided to conduct this study on factors that can impact the recanalization. So we retrospectively collected the data from digital and paper patients' records, and we analyzed them using the SPS statistics software. And we also analyzed follow-up angio CT scans of patients in our clinic. So here is the baseline of our patients. Most of them, around 80%, were female, and the age was above 40 years old. And the aneurysm diameter ranged between 2 and 13 millimeters, and neck size ranged between 1 and 5 to 6 millimeters. And also we analyzed one more parameter, which was dome to neck length. Here you can see all the flow diverter devices types, and the most common one was the Derivo device. And we had some postoperative complications. The most common one were distal embolism and stent thrombosis, and unfortunately, one patient died in the postoperative period. In the 6-month follow-up, significant recanalization was present in 12.41% of patients and slight recanalization in 7.55% of patients. And we analyzed various factors, including coils, including aneurysm diameters, etc. But the only one that was statistically significant was dome to neck length. And we found that dome to neck length was negatively correlated with aneurysm recanalization. In the 12-month follow-up, we did not have any findings that were statistically significant. However, it might be to the fact that we had a significant loss to follow-up, because we had 40% loss to follow-up. And here we had, I think, under 20%. So it was very, very much bigger here. And what is my take-home message? Dome to neck length is a factor that should be considered before a flow diverter device implantation, as it may lead to recanalization of an aneurysm and to more complications for the patients. Thank you.
Thank you very much. It's time for our last discussion.
Thank you for your great talk. In terms of white dome aneurysm, of intracranial aneurysm, so as you mentioned, you had a positive correlation. So the wider the neck, the higher the risk of recanalization.
No, I had a negative correlation.
Negative correlation. Yes. Yeah. So we've got a interesting proof. So those are aneurysms that are difficult to treat with coils. Yeah. So having a negative correlation here confirms that flow diverters should be used to treat white dome. Yeah. So there were, and it's a good strategy. Yeah. So there was, and the correlation was okay. Yeah. Yeah. So we confirmed that we are doing the right thing. Yeah. So we are. Yeah, so that's it. So we are qualifying our patients correctly, and your study confirmed what we are doing. Yeah, so that's it's always important, as those aneurysms are considered quite difficult to treat. Okay. So there was no background in correlations. So in sorry, I've lost the thread. So there were no comparison between flow diverter and classic coil approach.
No, unfortunately, we did not.
No. Okay. Yeah. So that's a very selected group of embolization. Anyway, really interesting. It's still not a solved problem. Yeah. As there's a lot of new flow diverters being researched. Thank you.
Congratulations. I'm not an interventional radiologist, so maybe I'm not the specialist. However, you analyzed your patients 6 and 12 months after the procedure.
Yes, exactly.
Did you also include the data just after the procedure? Because with flow diverter, I'm not sure, but sometimes you do not achieve the complete recanalization just after the procedure.
Our patients were only patients that were followed up after the surgery, and the surgery was successful. The procedure was successful. So
it was only flow diverter, or flow diverter with coils?
I think it was only flow diverters. I'm pretty sure. Yeah.
Mm-hmm. Thank you.
Thank you.
Thank you very much for your presentation and for the discussion.
Thank you so much.
Wszystkie prezentacje zaplanowane na sesję radiologii zostały wygłoszone. Cieszy mnie tak duża frekwencja, ponieważ odkąd prowadzę tę sesję, a zacząłem ją 3 lata temu, jest nas najwięcej. Rok temu nas było 4, 2 lata temu 5, a w tym roku mamy już 8 prac, więc jest progres, co bardzo cieszy. W tym momencie chciałem poprosić panią profesor o zabraniu kilka słów podsumowujących.
Po polsku czy po angielsku? To była bardzo duża przyjemność. My też uczestniczymy w tych sesjach już od kilku lat i muszę powiedzieć, że to jest wyjątkowo ciekawa, bo bardzo różnorodna. Było i serce, i radiologia interwencyjna, i dawki, i nawet kosmetyka, tak? Paznokcie. Także świadczy o tym, jak różnorodna jest radiologia, także każdy może znaleźć miejsce. Proszę Państwa, ja zawsze jestem pod wrażeniem tych prac, ponieważ Państwo wkładacie na to naprawdę bardzo dużo serca w to i naprawdę widać autentyczną wiedzę, także ja gratuluję.
Myślę, że nie należy.
Dziękuję bardzo pani profesor. W kwestii organizacyjnych poproszę osoby prezentujące dwie pierwsze prace o pozostanie, bo nie zdążyłem zanotować nazwisk. Druga kwestia organizacyjna. Wyniki zostaną ogłoszone w ten piątek na ceremonii zamknięcia o godzinie 18:00. Ceremonia nie będzie miała miejsca tak zawsze na auli A3 tutaj na kampusie, tylko w kinoteatrze Rialto w Katowicach. To miała być niespodzianka, ale tak będzie. Tak, więc wysoki zapraszamy. Zmiana wynika z tego, że nie zostało to może powiedziane na początku. Świętujemy naszą 70. już edycję konferencji. Z mojej strony to wszystko. Uważam sesję radiologii za zamkniętą. Dziękuję bardzo.